Hi, everyone. Welcome, welcome. We'll get started in just a moment. We'd like to wait for everyone to be able to join first. Okay, well, we'll go ahead and get started now. Welcome to the webinar. So grateful to have you here this evening. My name is Mandy Sandcooler. I'm the Director of Partnerships and Communications here at the Mended Hearts, Inc. And it's my absolute pleasure to be able to introduce to you today our two speakers, Dr. Anjali Owens and Gigi Imeson, who are going to be telling you more about a condition known as hypertrophic cardiomyopathy. And before I go into telling you a little bit more about these ladies' backgrounds, I just wanted to go over a few housekeeping items. All attendees for the session today are in listen-only mode, but we do encourage you to chat your questions into the Q&A box, and there'll be plenty of time at the end left for the speakers to answer those questions. Please note that questions about your specific condition or treatment cannot be answered on this webinar, but we encourage you to go back to your healthcare team and have them answer those questions. And then lastly, this webinar is being recorded and will be available on our website and our YouTube channel. We wanted to take this opportunity to share with you some of the resources we've developed over the last few years on HCM and cardiomyopathy. We have an excellent go-to guide, we have a patient journey, and we have a discussion guide, as well as additional webinars and other materials that you'll find helpful, I think, if you want to know more about HCM. So please use your phone to click on the QR code in the corner or go to the URL at the bottom of the screen. All of our resources are free. And lastly, I would like to thank PeerView Institute for Medical Education. We are bringing this webinar to you today in partnership with PeerView, and we're grateful for their support. Some of the things you're going to be learning on today's webinar, you're going to hear from Gigi, who's going to share her experience of living with HCM. You're going to hear from Dr. Owens, who's going to review the latest diagnostic tests and treatments used in managing the condition. You're going to learn how to work closely with your doctor to make the most out of each office visit. And you're going to get your questions about HCM answered at the end of the session, when we'll have plenty of time for Q&A. And before I let Dr. Owens take over, I'm just going to share with you a little bit of their background, Dr. Owens and Gigi's background. Dr. Owens is the founding director of the Center for Inherited Cardiovascular Disease and director of the Hypertrophic Cardiomyopathy Center at the University of Pennsylvania Perelman School of Medicine. She's an associate professor of medicine in the Division of Cardiology, section of heart failure, transplantation, and mechanical circulatory support. Dr. Owens completed undergraduate education in medical school at Duke University and then completed her residency, chief residency, and fellowship at the University of Pennsylvania. Dr. Owens has a special interest in genetic forms of cardiomyopathy and emerging novel therapeutics. Gigi's journey with HCM began in 1961 when her doctors first diagnosed her heart murmur at the age of 2. Since then, several of her family members have tested positive for the same HCM genetic mutation. Gigi is a strong supporter of genetic testing and believes it is critically important. Learning that many of her family members tested positive with the gene inspired her to participate in a clinical trial focused on new medication for HCM patients. Gigi recently celebrated her 43rd wedding anniversary, so congratulations, Gigi. She has 2 children and 6 grandchildren. And in addition to her busy family life, Gigi is a longtime Mended Hearts visitor and advocate. So thank you, ladies, both for being here. And with that, I'm going to turn it over to Dr. Owens.
Thank you, Mandy. And thank you for the invitation to speak today, and to the PeerView team, and for Gigi for joining me. So let's get started. We'll talk a little bit about an overview of HCM. Next slide. HCM, we know, is a condition that affects men and women, people of all ages, all ethnic backgrounds, and it can occur anytime in life from birth until your elder years. We know that when we look at studies of hearts, taking pictures of hearts by echocardiogram or ultrasound or MRI, that this condition occurs in at least 1 in 500 individuals. And again, this is worldwide. A take-home point is that the vast majority of individuals living with HCM are currently undiagnosed, and we'll talk a little bit about why that might be, but we have a work to do in terms of recognition and proper and timely diagnosis. We know that there are some disparities in care, and we see this throughout many cardiovascular conditions, including HCM, where women are diagnosed later in life with more severe disease at the time that they're diagnosed. And there are minority populations who also have disparities in diagnosis and care. The median age of onset is somewhere in midlife, and we do see that complications can accumulate over time, and I'll show you a little bit about that. Next slide. So what are the signs and symptoms that we think of when we're diagnosing hypertrophic cardiomyopathy? We know that the personal history and symptoms can vary tremendously. And it's important to know that there are some patients who are completely asymptomatic but have hypertrophic cardiomyopathy. When symptoms occur, they're generally cardiovascular or cardiopulmonary in nature, ranging from shortness of breath or shortness of breath with exertion, like exercise, dizziness or lightheadedness, chest discomfort that can occur at rest or during exercise, at times a feeling of irregular or fast heart rate or a pounding heart rate. We sometimes call this palpitations. And we know that the symptoms can vary from day to day. There are often good days and bad days in patients with HCM. When we do a physical exam in the office, you can be told that there's a whooshing sound or what we call a cardiac murmur. And I'll talk a little bit about why that murmur occurs in HCM. You can have an abnormal tracing or EKG, and at times you can have irregular heartbeat that's picked up on physical examination. A very critical part of evaluation for this disease is the family history, and you heard a little bit about that in Mandy's introduction, but this is a disease that can go from generation to generation. It's passed down through the generations, and so we take a family history that encompasses multiple generations of the family when we meet patients in clinic. And we're looking for anyone who has had an unexpected or sudden death, anyone who's had heart failure or stroke at an early age, and of course, anyone that's got a known diagnosis of cardiomyopathy. Next slide. Here is a survey from the Hypertrophic Cardiomyopathy Association, a patient advocacy group, and this survey went out to patients with HCM to see what their most commonly reported symptoms were. And as you can see here, shortness of breath is the most common, and that can occur generally with activity, so a feeling of breathlessness, particularly with inclines. We see that in patients with HCM, or a feeling of exercise intolerance, that they just don't feel like they can have the oomph to exercise. The other symptoms that we mentioned, lightheadedness, palpitations or irregular heartbeats, chest pain or pressure, are a bit less common, but still present. We know that factors such as a large meal or periods of high heat or humidity, periods of dehydration, or excessive alcohol use can worsen symptoms in HCM. And when we get to our pictures of the heart, I'll explain to you why that is. Next slide. So here's the heart. On the left is pictured a normal heart where we have 4 chambers of the heart, 2 on the top called the atrium, and 2 on the bottom called the ventricles. And when you focus your attention on the right-sided picture, the one with HCM, and bring your eyes down to the left ventricle, thank you, Mandy. This is showing the hypertrophy or thickening of the left ventricular wall. And that is what we see in hypertrophic cardiomyopathy, that the left ventricle, when you measure the walls, which has to be done by cardiac imaging, like an echo, an EKG is not enough, we measure those walls. And in a normal heart, the walls are 1 centimeter or less thick ballpark. So when we get above 1.5 centimeters, that's when we make a diagnosis of HCM, generally speaking. And there are two varieties of HCM. There's the obstructive form, and that means that it's difficult for the blood to exit the heart. When the heart squeezes and the blood is going out to the large blood vessels, there is obstruction to the flow of blood. This has nothing to do with the arteries in the heart, but really the cavity itself, where the thickened wall is in the way as the blood tries to go past. And then we have a form called non-obstructive HCM, where there is no obstruction to the flow of blood. And this will become more clear on the next slide. So here's a number of pictures of what your heart can look like with hypertrophic cardiomyopathy. And you can see that there's a wide variability of what hearts with HCM can look like. On the top left is a normal heart. And then down on the far left is a heart without obstruction. The left ventricle walls are thickened, but they're not causing obstruction to the flow of blood. And in the middle is a heart where the septum, or the middle wall, is the thickest, and there is obstruction to the flow of blood, and Mandy is pointing it out there. And there's the leaflets of the mitral valve that come over and touch the septum, and when that occurs, the blood can't get past, and you can see how that area narrows significantly. And when that happens, the blood is unable to exit your heart. It's difficult to exit, and you can feel lightheaded, you can feel dizzy, you can have chest pain, you can have shortness of breath. And this is dynamic. It depends on how filled up with blood your heart is. So when you're well hydrated, there's less obstruction. When you're dehydrated, there's more obstruction, and that gets to some of the recommendations we give for patients with obstruction to stay well hydrated, to avoid periods of high heat and humidity. There's also a variant or a type of HCM where it happens more in the middle of the left ventricle, and we call that mid-cavitary. And you can see the thickening of those pink walls occurs further down, as Mandy is pointing out. And you can get an outpouching at the tip of your heart in that condition. And finally, we have on the far right what we call the apical type of HCM. And that's where the thickening occurs really at the tip of the apex of the heart. And it's really just critical to know that you need an echo, an ultrasound of the heart. And if we're not able to see well enough, then you need a cardiac MRI in order to make this diagnosis. Next slide. So how is HCM diagnosed and treated? We'll talk a little bit in the next section about what the options are. Generally speaking, we start our testing with a physical exam, and then we move to the EKG. The EKG is a tracing of the electrical pattern. That's by putting stickers on the chest wall and taking the picture that you see on the left. That is your EKG. And we can tell if the walls are thickened by the pattern that we see on the EKG. Important to note, a normal EKG does not rule out HCM. There are some patients who have a normal tracing or pattern, but still have thickening when we measure the walls. And that really must be done by echo, which is pictured in the middle. That's the ultrasound where you see the beating heart and the colors. And we can tell whether or not there's obstruction to the flow of blood by looking at those colors and measuring the pressures. And I am showing a heart there that has a thickened middle wall or septum. And then on the right, if we can't see well enough by echo, we move on to something called the MRI. And that's on the right, the black and white and gray images. And you can see there that there is some obstruction to the flow of blood right where that dark cloud comes in. That tells it that there's turbulent flow when the blood is trying to exit the heart. We very frequently also do exercise tests for patients with HCM because sometimes you have no symptoms at rest and your heart looks fairly good at rest, but when you try to exercise, that brings out the obstruction and we're able to measure it just after you get off the treadmill. So it's very common that we'll do an exercise test if we're suspecting the obstructive form of HCM. Next slide. Hypertrophic cardiomyopathy can commonly be misdiagnosed, and that's because the symptoms overlap with other cardiac or heart or lung related issues. And one of the most common that we see in our clinic is young people who are told that they have exercise induced asthma. And that's because they become short of breath. They can even have wheezing when they exert themselves. And so it's very common to have asthma when you have a 22-year-old. It's not infrequent that we see that they've been told they have asthma. However, when they try an inhaler, oftentimes it does not help their symptoms. And in some cases, it can even make the symptoms worse. So that would be one sign. Another common misdiagnosis is mitral valve prolapse, and that's that mitral valve that's in the middle between the two left-sided chambers. And because the physician hears a murmur, they assume that it's mitral valve prolapse, but really it's obstructive hypertrophic cardiomyopathy. We also see oftentimes young people told that they have what's called an innocent heart murmur, which is just a flow murmur that doesn't have any disease associated with it. And that can be because the murmur is intermittent. It comes and goes. But with HCM, it's coming and going based on how hydrated you are, what your blood pressure is. And so it can be confusing. And the final two is that we see, unfortunately, usually a disproportionate amount of women who are told that they have panic attacks or anxiety attacks. And that might be because they feel their heart flip-flopping or having palpitations, and that does make you anxious. But it's not that they're anxious first, it's that there's something going on in their heart. And it's really important that we do monitors like EKGs, but at home. So we can send you a monitor to wear. It's like a sticker that you put on your chest, and we can measure your heartbeats and look at them and see when you're feeling that symptom of anxiety, what's happening with your heart rhythm. And we've seen that that can occur, that a woman is told she's anxious and really it's an arrhythmia. And finally, we see that fainting episodes are often attributed to something else, some other reason for fainting and not related to the heart. Next slide. In a study that we recently did of about 3,800 adults with obstructive HCM, we found that almost 60% had a misdiagnosis, or what I'll call a partial diagnosis, on their journey to being found to have HCM. And the vast majority saw a cardiologist. They saw a cardiologist multiple times. And what we frequently see when we take a history from patients is that they're told they have some other issue, a slight abnormality in the heart muscle. They're told that they have atrial fibrillation, but they're never told why they have atrial fibrillation because of an underlying heart, structural heart disease like HCM. They're told that they have atypical chest pain, but no one figures out that it's the HCM causing their symptoms. And so on average, we find that patients may have a delay in diagnosis of months to years. Next slide. The importance of genetic testing really comes up when we evaluate patients in clinic and after we've made a diagnosis of hypertrophic cardiomyopathy. So the way that we use genetic testing, and Gigi will tell us more about how this played out in her family, when we find a patient and we diagnose them with hypertrophic cardiomyopathy, we usually do a counseling session with one of our genetic counselors who works with us in clinic. During that time, we take that multi-generation family history so that we understand if other people in the family are known to have HCM. And then we do the genetic testing. And during the genetic testing, we look for a change in the DNA, which is the code that tells your body how to make all of the organs. And if there is a change in the code or a misspelling in that code that we know can be associated with hypertrophic cardiomyopathy, then we can use that information to risk stratify family members. And what that means is with HCM, if you have hypertrophic cardiomyopathy, there's a 50-50 chance, like the flip of a coin, that you'll pass on that genetic change to each child. So each child has a 50-50 chance. And if the child inherits that genetic change, that change in the DNA that we know causes HCM, then they are at risk to develop HCM at any point in their life. Even if their heart is currently normal, we know they're at risk to develop HCM. And those are the folks that we follow closely over their lifetime. We keep doing echoes and EKGs to see if they're showing any signs of HCM. If you don't inherit the genetic change that causes HCM, again, a 50-50 chance if your parent has it, that you'll get it, and you happen to not get it, then we don't think you're going to be able to develop HCM in the future, and we can release you from screening, meaning you don't have to come back for the echoes, the EKGs, etc. This disease does not skip generations. So if a child did not get it from their parent, then they can't pass it on to their children. So it can be very informative and helpful for families as they determine who in the family is at risk and who is not. Now, we are not smart enough to identify every single genetic change, and all of the genes are not yet understood. So we do have families where we can clearly see a pattern of HCM going through the generations, but we can't pinpoint the abnormal genetic change. And in those families, we cannot use the genetic testing. We have to continue to look at everybody's heart to see if they develop HCM over time. Next slide. So the treatments for hypertrophic cardiomyopathy vary based on what we're aiming to prevent. So on the top of the slide here, I have some of the major complications that can occur in patients with HCM, ranging from the most feared complication, which is sudden death or sudden cardiac death. Fortunately, this occurs rarely in HCM, but of course we'd like to prevent every single episode if we can. And there's a device called an implantable defibrillator. I'll show you a picture of it in a couple of slides that can be used or implanted for the rest of your life to prevent sudden death. Not everyone needs one, but some people do. The next complication is that obstruction to the flow of blood as it tries to exit your heart. And we use medications, and we can use surgeries or catheter-based procedures, and I'll show you a picture of those to reduce that obstruction. And we have a new class of medications that's been recently approved by the FDA that also works for obstruction. We have a small percentage of people who move to what we call an advanced stage of heart failure. So this is typically patients who don't have obstruction, they're non-obstructive, but their heart has gotten very sick. And at that point, we do try medications and devices, special pacemakers in some situations, but our last resort for those patients can be a heart transplant. And we're hopeful that in the future, we will have other medications to use for this group of patients. And finally, we think about atrial fibrillation, which is a heart rhythm abnormality. It's where the top of the heart is no longer beating normally. It's fibrillating, it's beating very quickly. And when that happens, the heart can beat erratically and blood can pool in the heart. When that happens, a blood clot can form, and you can be at risk for a stroke because that blood clot can travel out of your heart and go anywhere in the body. And what we do in those situations when someone has AFib is we put you on a medication, sometimes to suppress the AFib. We always use a blood thinner when you have HCM and AFib to reduce the chance of having a stroke. And there are ablation procedures that are available. Those are invasive procedures to try to correct the heart rhythm. Next slide. So these events, again, are fortunately rare in terms of sudden cardiac death. This is from a large registry, the SHARE registry. At the time of this publication, there were about 6,000 to 7,000 patients in the registry with HCM. And you can see that the very concerning endpoints like cardiac death are rare. But atrial fibrillation, for example, happens in about a quarter of patients with HCM. About 18 to 20% of patients in this registry needed a procedure to reduce the size of the septum, and there were a fair number of people who developed heart failure symptoms. So these are real complications that we watch for over time in our patients with HCM. Next slide. Here's a picture of that defibrillator. Again, this is a device that's used in patients who are deemed to be high risk to have an arrhythmia or to have sudden death. And it's a device that's surgically implanted. We have a number of them available. They go in various places on the chest. And there's a wire that goes into the heart with some of the devices. Some of the newer devices don't have a wire that goes into the heart. But the whole premise of the device, the way it's used, it's like having the paramedics with you watching each heartbeat. And if you go into a life-threatening arrhythmia or electrical problem, then device will spring into action. It's like having the paramedics. Instead of delivering a shock electrically on the outside, the device delivers the shock from the inside of the heart, and it puts you back into a normal rhythm. Not all patients with HCM need this device. We use a series of risk markers. Some of them are listed here. And in shared decision making with your cardiologist, we decide whether or not you're high enough risk to need this type of device. Next slide. There are two invasive procedures that we use to treat obstruction. And again, that's when it's hard for the blood to get out of your heart because the thickened muscle wall. And I've shown you here just a cartoon of the two procedures. On the left is the septal myectomy. That's open heart surgery. We come in through the aorta, and the surgeon uses a small knife to shave off the size of the septum. And Mandy is pointing there at the knife coming down into the septum, and that thins out the heart muscle wall. And on the right is the alcohol septal ablation. This is a procedure that's done through a catheter. So like a catheterization, goes through the groin or the arm. You do not have to open the chest. And we go in with a little tiny catheter that Mandy is pointing to, and we find the artery that gives blood supply to that thick part of the muscle, and we inject a little bit of alcohol. It's a controlled heart attack, if you will, that makes some of that muscle tissue die so that it thins out. And what the whole purpose is to allow the flow of blood to exit more easily out of the heart. As you can imagine, these are very specialized procedures, and they're best performed at centers that do a lot of them. We get the best outcomes at high volume centers. Next slide. So the new class of medications that have also now been used and FDA approved for obstructive hypertrophic cardiomyopathy are called the cardiac myosin inhibitors. There is one drug that has been FDA approved and another drug that has made it through to phase 3 clinical trials. And these drugs work by reducing the force of squeezing of the heart. And usually in HCM, the heart is squeezing too hard, and these medicines bring it down to more normal squeezing. And when that happens, we find that the obstruction goes away in the majority of patients, and it improves symptoms, exercise tolerance, quality of life, and reduces or resolves obstruction. And we know from several clinical trials now that this can decrease the need for surgery, which is excellent for some patients who do not wish to have an invasive approach. Next slide. Because of the way that this new class of medications work, we do follow by echocardiogram. That's the ultrasound of the heart. And we use that echo to see how the heart is responding to the medicine. We want the obstruction to go away, but we don't want the heart to get too far in terms of squeezing function. We want it to remain in the normal range. We don't want it to go too low. We don't want it to be too high. We want it to be in that middle range. And we use echocardiograms to assess how the heart is responding. And these echoes have to happen regularly if you start this class of medication. Next slide. So one thing I would encourage all of you to do is to talk to your doctors about clinical trials, not just for myosin inhibitors, but there are other new medicines that are being developed for HCM. We've entered an era where we're actually targeting our medicines to the underlying problem, and that is really key. because prior to that, for the last several decades, we've been using other medicines that were not developed for HCM. And now we're developing medicines specifically for HCM. So if it's something you're interested in, certainly talk with your team about that. Next slide. This is a final reminder to pay attention to the rest of your body as well. We know that conditions like obesity, sleep apnea, high blood pressure, AFib, blockages in the arteries, all can affect your HCM and it can make them worse. So we want everyone to pay attention to their overall cardiovascular health, to talk with your physicians about all of these other issues that are very common in our US population and treat those as well. Next slide. So I will stop here, and I'm excited to pass it on to Gigi so we can hear her story.
Okay. Thank you, Mandy, and hello, everyone. I'm here today to share my story of living with HCM, which for me started in 1961 at the age of 2, when I was found to have a heart murmur. I had a heart cath 2 years later and was diagnosed with what they called a misplaced heart bundle. This thickness is what we now know to be a finding consistent with HCM. At that time, my doctors did not require any real follow-up nor any activity restrictions, so I later participated in both high school and college sports. In 1981, my fiance suggested I get my heart rechecked before graduating from college and losing my parents' health insurance. So I had another heart cath and my first echocardiogram, which was a newly minted diagnostic tool at the time. I was diagnosed with IHSS, which we now call HCM, and my doctors told me to avoid strenuous exercise and get a follow-up echo every year. 3 years later, at the age of 25, I started to experience my first HCM symptom, lightheadedness, and was prescribed a beta blocker. In 1987 and 1991, I had my 2 beautiful children without any cardiac complications. The extra monitoring and extra doctor visits must have paid off. Between 1991 and 2008, my beta blocker kept me pretty much symptom-free. I even felt well enough to participate in recreational volleyball, softball, and doubles tennis. In 2008, however, at the age of 49, I started having shortness of breath with exercise. I was referred to Stanford, as they have an HCM Center of Excellence. Expecting maybe a change of meds, I was surprised to learn that they recommended either a septomyectomy or an alcohol septal ablation due to my pressure gradient. I appreciated my doctor's help with this decision-making process, as he set up appointments with both the cardiac surgeon and the interventional cardiologist. I chose to have the alcohol septal ablation as it was much less invasive and had such a good result that my murmur nearly disappeared. The following year, I had a TIA and was diagnosed with paroxysmal AFib, for which I was prescribed a blood thinner and an antiarrhythmic. Later that same year, I had an ICD placed upon learning that my cousin, whose father died suddenly at an early age, had just been diagnosed with HCM. In 2010, I received genetic testing and had the MYH7 mutation. Stanford then strongly recommended testing for my children, siblings, nieces, and nephews. This led to one of the most frustrating parts of my heart journey, in that most of them did not want to get tested. They told me they felt fine and had no symptoms, but I continued to plead with them for the next several years. In 2015, my AFib went from paroxysmal to persistent AFib, which caused me to be hospitalized for congestive heart failure. A cardioversion ended my AFib temporarily, but I needed a cardiac ablation a few months later. In 2016, I had yet another discussion with my genetic counselor about my family's reluctance to test. She decided to write a letter to share with my family, explaining the importance of genetic testing and follow-up care. This finally got their attention, and 15 family members tested. 10 of the 15 had the MY87 mutation, including 3 siblings and 1 niece, who also got ICDs placed upon follow-up. So how important is genetic testing and follow-up? Well, these 3 siblings have all had their ICDs shock them at least once so far. In 2018, I experienced my own ICD shocks, which led to another cardiac ablation for AFib, as well as counseling for PTSD. I was afraid that my ICD wouldn't work the next time I needed it. With time, my anxiety eased, but I had never before felt so vulnerable on my heart journey. Last year, I moved my healthcare to UC San Diego. They also have an HCM Center of Excellence, and I was invited to join the drug study of mavacamten for non-obstructive HCM patients. I don't know if I took the mavacamten or a placebo over the last year, but I never really noticed any changes in my symptoms or exercise tolerance. Last month marked the end of my first year of the study, and I was started on a low dose of mavacamten. I didn't notice any improvement after my first week, but after 3 weeks, I'm happy to report that climbing a flight of stairs now seems a little easier. I am hopeful that my symptoms will continue to improve along with the treatments for HCM. Thank you for listening to my story.
Wow, Gigi, thank you so much. That was really powerful on so many different levels. I'm sure there will be plenty of questions for you at the end. We're going to go ahead and finish. Dr. Owens is going to finish the rest of the presentation, and then we'll open for questions. Thank you.
Thank you, Gigi. And you really read the textbook on HCM. Every single thing I mentioned, you had in your personal history. I mean, that's pretty remarkable. And you've made it through it all, thank goodness. So the final few slides are really just about working closely with your physician team to make the most out of your office visits and how to work together in a shared care model. Next slide. So HCM management, we say, is a team sport, and there are a number of people on the team. The most important person is, of course, our patient. So you are the center of the team. Your opinion matters. We want you to be informed. We want you to advocate for yourself. You may at times have to manage a number of different physicians, including an HCM specialist, a local cardiologist if you travel elsewhere for your care, an electrophysiologist who might manage AFib or your defibrillator. You interface with genetic counselors. Of course, you have your primary care physician. You may have interfaces with surgeons or interventional cardiologists. So this can be a lot to manage. And I think that you need to have sort of a quarterback and the team all in agreement. And it's important that we communicate with one another. So it's not unreasonable to expect that. And if you're not getting that kind of coordinated care, please advocate for yourself so that we can get you the right care. Next slide. There are centers of excellence as designated by the Hypertrophic Cardiomyopathy Association. Here is a schematic of the United States and where the centers are. And suffice it to say that we are getting way better than we were, but there are still large portions of the United States where you would have to travel a great distance to get to a center of excellence. And so it's important that we are able to get care to everyone in the US, and that's one of the things that we want to work on in the years to come. Next slide. In terms of who does what, I think it's important to have roles for all of the care team. And it's important, as I mentioned, that we coordinate with one another. The HCM Center, I would say, should be the go-to if there is a major decision to be made with regard to HCM. And that can be whether a septal reduction therapy is needed, like Gigi met with a surgeon and an interventional cardiologist and her HCM team to make that large decision. If a defibrillator needs to be placed, if an ablation needs to be done, if you're a competitive athlete and you want to talk about ongoing competitive sports, those are major decisions that should be made in conjunction with the HCM Center. Your local cardiologist is critical to coordinating the care in between those visits and to be your point person if there is an episode of rapid AFib and you end up in the local ER in congestive heart failure or some other reason that you need that local physician to help to coordinate your care. We often also include behavioral health specialists or counselors, genetic counselors, and psychologists to deal with the effects of HCM. And at times, the guilt that can come from thinking that you've impacted a family member. And we see this at times with the genetic testing, and it's important to be able to deal with that head on. Next slide. Symptoms to share with your physician, I would say share all of your symptoms. And it's often that we see that patients kind of make their world a little smaller and they may not realize that they're becoming symptomatic. They just kind of subconsciously avoid things that don't make them feel well. So for example, they might avoid the hill when they're taking their dog for a walk and go the other route. So any kind of limitations that are progressive or that are different than what you were the year before, certainly share that with your team. Next slide. Shared decision making is a term that we use in the medical field, but really what it means is to have a conversation with your patients, have a conversation with the other consultants or the specialists. And we like to say that this is a really critical part of care. And as the patient, I encourage you to ask questions. Come with a list of questions, prepare for your visit. If there's something you don't understand, ask the physician to say it in non-medical terms so that it's very clear what your options are, and take time to think about it. Don't be afraid to get a second opinion. We all value second opinions, and I think that it's important to get the expertise that you need, particularly when you're making large decisions that can affect your life and your quality of life. Next slide. So key takeaways, and then we're happy to take some questions. Hypertrophic cardiomyopathy is one of the most common genetic causes of cardiomyopathy, but it's frequently misdiagnosed or underdiagnosed. Cardiac imaging with either an echocardiogram, which is that ultrasound, or if needed, an MRI, is really critical in making the diagnosis. We've got to measure the walls of the left ventricle to see if they're thickened. Family members, once someone is diagnosed with HCM in the family, need to see a doctor to look for signs of HCM, and an EKG is not enough. You really need the imaging in order to measure the heart walls. Genetic testing can be utilized for risk stratification for family members who are interested. And drugs and procedures can help you. We have a lot of things in our armamentarium, and there are new things being researched and being developed that are targeted specifically to HCM. So it's an exciting time to have this condition because there are options for treatment. And it takes a team to manage HCM. And of course, as the patient, we want you to be at the center of the team. So I will stop there and happy to take some questions.
Thank you both. Dr. Owens, that was such a clear description of the condition and the treatments and therapies, so greatly appreciated. Some questions. Let me see, starting there. Anonymous attendee asked, did your family, so this is Gigi, did your family ever think that you were just using HCM as maybe an excuse? Like, did you ever, especially I think as a woman, sometimes our symptoms might be overlooked. So in your journey, your heart journey, did you ever have to deal with people saying, oh, not taking you seriously?
No, I really didn't experience that with my family or the public.
Yeah. You're lucky. And I think you're lucky that you were diagnosed at such a young age, so you had documented proof of what you were going through. Dr.
Right.
Owens, do you find when you're dealing with some people that they're just, poo-pooing it for years, or other people are saying it's, just an excuse for being out of shape or not having the proper nutrition, etc.?
Yes, unfortunately, we do see that patients have symptoms starting in their teenage years or in their early 20s, but they really don't get a proper diagnosis until much later. And it can be because the symptoms are variable, and so some days are good, some days are bad. It can be because the proper testing isn't done. No one goes far enough to actually do the echocardiogram. Or it could be that they were given a label of something else like asthma and no one ever really looked at their heart. So we do see that frequently, and it's important to just raise awareness for the physicians that hypertrophic cardiomyopathy, what it means, and how you make the diagnosis so that we can avoid those misdiagnoses in the future.
Yeah, and then I had that question, and so does another attendee. What do you do if you think you've been misdiagnosed? What's the next step? And then my second part to that is, what's the medical community doing to educate more physicians about HCM and cardiomyopathy?
I think what we're doing as a community is really trying to do educational seminars, webinars, increasing amounts in the literature about studies for HCM so that we can bring it to awareness. Going down to the level of our medical students and their training to really bring cases of hypertrophic cardiomyopathy so that they know here are some of the signs and symptoms and things that we should look for. In terms of if you're a patient and you feel like you may not have achieved the right diagnosis, I would encourage you to start with a second opinion. And if you think it's hypertrophic cardiomyopathy or any kind of heart muscle disease or cardiomyopathy, go to one of the centers of excellence and specifically seek out an evaluation, and have that expert sort of look at your story, look at your heart, do any additional testing to see if they can get to a proper diagnosis.
Thank you. We have a question about the symptoms of HCM. Are they worse in warmer weather, hot weather? And why is that so?
Yeah, we frequently see that the summertime months, particularly with high humidity, can be difficult for our patients with hypertrophic cardiomyopathy, in particular the obstructive form. And the reason is that anything that makes your heart less full when you have the obstructive form of cardiomyopathy can worsen the obstruction. So, hot, humid weather where you may be dehydrated, you're not drinking as much as normal, can make your heart less full, and that can worsen the gradient or the degree of obstruction. So it's important not to do strenuous exercise when it's very hot and humid, and to take care to stay extra hydrated. We typically tell our patients to drink more than 64 ounces of fluid in a day of non-caffeinated beverages, and you might even have to do more than that when it's particularly hot and humid.
And Gigi, do you find that true in warmer weather where you're at in California? Do you have to be more careful?
Yes, especially if I go to Southern California and experience humidity. That can be a problem, as well as
Yeah.
just about the meals afterward too. I do notice that too. I have more shortness of breath immediately after a meal.
Very common symptom and one that can differentiate HCM from other conditions. So it's an important question to ask for the providers, is to say, how do you feel after a large meal? And what we often find is patients might alter their eating habits somewhat subconsciously to say, if I eat that large dinner, I am not feeling well. I can't go for a short walk. I'm feeling chest discomfort or shortness of breath. And so they kind of
Mm-hmm.
alter it to eat smaller meals throughout the day to avoid that large bolus of food. And the reason is your blood has to go to your gut to digest the food. And anything that makes your heart less full will make your symptoms worse. So the blood has been shunted over or sent over to your gut to digest the food, and your heart's a little less full, and you get more obstruction.
That's really interesting. Thank you for explaining that. Moving into the genetic testing, Gigi, that you're such an advocate for, a quick question, your advice to the audience as to why genetic testing is so important then, and are there other, I think having that idea of having your doctor write a letter was such a good one and something that other people can actually use. Do you have any
Mm-hmm.
other advice for them? And can you just tell us, do you get out there and get that message about genetic testing out to people?
Well, I think the genetic counselors, at least I've found, are mostly at the HCM Centers of Excellence. And that's where they really push the genetic testing. And as you can see in my own family, I mean, some of them thank me that I saved their lives because their ICDs have gone off appropriately at least once now, some more than once. So that's why I just feel so strongly about it.
And Dr. Owens, are there enough, in terms of genetic testing and the availability of it, are there enough genetic counselors right now to meet the needs? Or do you see as more people want it, will we be able to keep up with that?
Yeah, we definitely have a shortage of genetics professionals in terms of the number of patients who are eligible for genetic testing. We are not doing a good job at finding all of those patients and having counseling and testing offered to them. So hypertrophic cardiomyopathy is one of the cardiomyopathies that can be inherited or passed from generation to generation, and there are others. And we look at all of those cardiomyopathies and arrhythmia syndromes together. There are a lot of patients who are candidates for genetic testing, and it really even starts with a very basic multi-generation family history. And in many cardiology clinics around the country, there just isn't enough time built into those office visits for the cardiologist or their team to do a basic family history. So one of the key things that genetic counselors provide is that detailed family history that's really critical, because we make a lot of our decisions based on what we find in the family. And so, I advocate strongly for additional genetic counseling programs, training programs, disseminating that information to other healthcare professionals who can then learn that information and be extenders even for our genetic counselors, so that we can get the right counseling and testing to all the families and their family members. And the letter is a wonderful way to do it. So our genetic counselor will put together a family letter. It has the information in it, and it tells people what care to seek to get their heart checked and what the options are for genetic testing. And in our country, where care can be scattered across, state lines, and our healthcare systems, electronic medical records don't all talk to each other. It's really difficult to disseminate this information to families that may be across the country in rural areas. So the use of a letter is great. And then the patient doesn't have to explain every little detail. They can say, here, take this and take this to your medical professional so that they can understand what needs to be done.
And when they get it from a genetic counselor and not just you, I think that gives it more validity.
Absolutely. Absolutely.
Mm-hmm.
Yeah. In terms of where the genetic counselors are working out of those centers of excellence, and they're not everywhere. So if you have someone who wants to be seen at one of those centers, do they have to get their doctor to refer them? Can they go on their own? What does it look like for someone who lives somewhere where, it could be 3 states over to get to one?
Yeah. So some of it depends on your health insurance. If it's in state, then oftentimes you're able to get a referral from your physician or, primary care doctor even, to go to a center of excellence. If it's across state lines, it can be difficult from an insurance standpoint. There are more and more telemedicine programs. We have one at our center where we offer to do genetic counseling and testing for centers that are remote, hospital systems that are remote, where the patients have a difficult time traveling to us geographically. So we'll offer telemedicine genetic counseling. We're able to do the pedigree or the family history via a Zoom type platform, HIPAA compliant, and then we can get the sample done via saliva, and we can ship out a kit to them in the mail, and they can send that kit to the company for testing. So there are ways to do this kind of remotely, as long as you can coordinate with the center that does it. Some of the commercial genetic testing companies also offer genetic counseling. So it's not an in-person counselor like you would get in a clinic, but it is a genetic counselor that works for the genetic testing company, and they offer that service for various patients as well. So that's another way to perhaps access genetic counseling if you don't have it as part of your local team.
Thank you. Thank you. Gigi, I wanted to touch on the clinical trial that, you just finished up one, and more patients are being offered this option to participate in different types of trials. And we at Mended Hearts, we advocate for patients to be able to have that choice. What would you say to someone who's considering doing a clinical trial, and what made you do that? And how do you feel about it now that it's finished?
Well, what made me do that, my family inspired me to do it because a lot of them are younger, and I'm hoping that, this will help with their future HCM journey, as well as other HCM patients. I would say that I had a good experience. The team was very good here at UC San Diego, and I would highly recommend it. Now I'm taking the real drug, and we'll see what happens, but at least I had that opportunity.
And Dr. Owens, you could probably speak to this. Do people normally have to pay anything to be enrolled in a clinical trial?
Generally speaking, no. There often is some compensation for your time if you decide to enroll in a clinical trial. So you can get a stipend for participation. Some of the clinical trials will help to support your travel or pay for your travel if you're going frequently to the testing center. And they will pay for all of the tests that are done as part of the clinical trial. So if you get an echocardiogram or an MRI or an EKG as part of the trial, the company that's sponsoring the trial will pay for that.
I do say you have to watch on your medical billing, because I'll go in and say that this is research, and they'll say, okay. And then next thing I know, I have a bill for the service. So that's been probably the main problem during the whole study, but it gets taken care of. And I just think it's been a really good experience.
Yeah, thanks, Gigi. We've got 2 minutes left, and there are a couple of specific questions, Dr. Owens. What's the difference between HCM and idiopathic CM?
Idiopathic cardiomyopathy really refers more to a dilated form of cardiomyopathy where the heart muscle becomes enlarged and the walls are thin, as opposed to HCM where the heart is thick. And with idiopathic dilated cardiomyopathy, the heart doesn't squeeze hard enough. So it's over here, it's weakened, and it's not squeezing hard enough. With HCM, the heart is thickened and stiff and generally squeezes too hard. So a little bit on the opposite end of the spectrum, but still a cardiomyopathy, and one that can be inherited.
And I think there's time for one last question. What's the difference between exercise SOB versus being out of shape?
It's a hard one because you can get short of breath from what we call deconditioning. You just haven't exercised in a while, or from something related to your heart and lungs. And one good way to differentiate or tell the difference between those is a fancy exercise test. It's called a VO2 stress test or a cardiopulmonary exercise test. And we put you on a treadmill, and you also wear a mask, and it can tell us what is the reason that you stopped exercising. Was that your muscle pooped out, your heart pooped out, or your lungs pooped out? And that can really give us a lot of specific information as to what your limitation is.
Thank you. And sadly, we are out of time. This hour flew by. We're so grateful to you both. This was really an excellent and informative session. I know on behalf of all the attendees, a big thank you. And with that, we'll go ahead and end it for the evening. I hope everyone has a good night. Thank you.
Thanks, Mandy.
Bye.
Thank you, Mandy.
Thank you, guys.
Bye-bye.
Bye.
Bye-bye.